Welcome, everyone, returning back to understanding basic ECG. In this lecture, we will discuss one of the most important foundations in ECG interpretation, which are the ECG leads, how to record the ECG. Before interpreting abnormal cardiac rhythm, axis, ischemia, or different types of arrhythmias, we must first understand what the leads actually represent and how the ECG views the heart. Standard ECG uses 10 electrodes to generate 12 views or camera angles of the heart. A useful analogy is to think of the ECG as placing 12 cameras around the heart. Each lead looks at electrical activity from a different direction, and this allows to localize the abnormalities and to know, for example, if the patient has anterior infarction, has inferior infarction, has lateral ischemia, has left or right bundle branch block, and many other conditions. The ECG, therefore, gives us a three-dimensional understanding of the cardiac electrical activity. Now, let us divide the ECG leads into two major groups. First, limb leads, leads 1, 2, 3, and the augmented leads, AVR, AVL, and AVF. These leads look at the heart in the frontal or vertical plane. Second, the pericardial or chest leads, V1 to V6. These look at the heart in the horizontal or transverse plane. An important conceptual distinction, lead 1, 2, and 3 are bipolar leads. So they record the electrical activity between two electrodes, and the augmented leads are unipolar leads. They compare one electrode against the average of the other two electrodes. So lead 1 records the electrical activity between the right arm and left arm, and lead 2 between the right arm and left leg, and lead 3 between left arm and left leg. While AVR, it is like looking at the heart from the right shoulder, and AVL from the left shoulder, and AVF from the left leg. Just to remember, the bipolar leads 1, 2, and 3, it is like putting a camera between 2 points to record the electrical activity. But the augmented leads, AVR, AVL, AVF, it is like putting single camera at single point to look at the heart. Here you can see what we mentioned in the previous slide, that the limb leads, both unipolar and bipolar, form 360-degree views of the heart, and it looks at the vertical and the frontal plane, and the chest leads from V1 to V6 looks at the transverse plane of the heart. So this image demonstrates another way of arranging ECG leads, which is called the Caprera format. And in this format, the limb leads are displayed sequentially according to the anatomical angles around the heart, as you can see. It is drawn in a manner showing the angles of different leads. This arrangement helps to visualize the heart in more continuous circular manner and can make interpretation of the cardiac axis. We'll come later to this in the lecture of the cardiac axis, but let me explain to you from where this figure has come. So can you see here, this is lead 1, and lead 1 comes here between 0 and 180 degrees, and lead 2 comes here at 60 degrees, and then lead 3 is in this direction, so lead 3 comes here in 120 degrees. And then the AVR will come at 30 degrees, and AVL between minus 30 and 150 degrees, this vertical line, and AVF at 90 degrees. So if you do it like this, lead 1, and then lead 2, and then lead 3, and then EVR, EVL, and EVF, you will get this figure. Now we have come to a very important practical topic, which is the electrode placement. It is very important because incorrect lead placement can completely distort the ECG and may even falsely suggest serious disease such as myocardial infarction, which is not there. Remember that we use 10 electrodes to record the 12 leads of the ECG. We have 4 limb electrodes and 6 chest electrodes. The 4 limb electrodes, as you can see, red in the right arm, black right leg, green left leg, and yellow left arm. I think you can notice that the right leg one is the ground one. So lead 1 records the electrical activity between right arm and left arm, and lead 2 between right arm and left leg, and lead 3 between right arm and left leg. So if we look at the chest leads, which as we know from V1 to V6, so anatomically V1 is in the fourth intercostal space, right sternal border, and V2 it is in the left sternal border, fourth intercostal space as well, the same space, and V4, 5, and 6, they are all in the fifth intercostal space. V4 at the apex, fifth intercostal space, mid-clavicular line, V5 anterior axillary line, and V6 mid-axillary line. And V3 is between V2 and V4. If you like to remember the colors, you can use this mnemonic. Ride your green bike very gently, but don't worry, you will find each one of the electrodes labeled with the lead number. So these different leads gives different views of the heart and correspond to different anatomical regions of the heart. This is one of the most clinically useful concepts in ECG interpretation, as it gives us the ability to localize the site of cardiac pathology. So some of the leads looks at the anterior wall of the heart, some looks at the inferior wall of the heart, and others look at the lateral side of the heart. Therefore, for example, ST elevation or ST depression or T wave inversion in certain leads can point at the site of myocardial infarction or myocardial ischemia. Now, let's look together at how different limb leads looks anatomically at the heart. So if we ask what are the leads looking at the inferior surface of the heart, we'll find that if we take a line here, you will find that inferior surface of the heart is facing lead 2, 3, and EVF. So 2, 3, and EVF looking at the inferior surface of the heart, which is the territory of the right coronary artery. And lateral leads or lateral surface of the heart, if we take a line here, we'll find the lateral surface of the heart facing lead 1 and AVL. So clinically, if you have ST elevation in leads 1 and AVL, can indicate lateral infarction. If ST elevation is in leads 2, 3, and AVF, it can indicate inferior myocardial infarction. So what about the chest leads? V1 and V2 looks at the right ventricle at the anterior surface of the heart. V3 and V4 looks at the septum. So if I have lesions between V1 to V4, it is anteroseptal. And V5 and V6 looks at the lateral surface of the heart. Oh, we remember from the previous slide that also lead 1 and EVL looks at the lateral surface of the heart. If we put all together, 2, 3, and AVF represents inferior surface of the heart, anterior surface or anteroseptal V1 to V4, lateral surface leads 1, AVL, V5, and V6, And V1 and EVR looks at right atrium and left ventricle cavity. If we put what we learned together on the ECG strip, you'll find the lateral leads, lead 1, AVL, V5, and V6. 2, 3, and AVF are the inferior leads. Anterior and septal are V1, V2, V3, and V4. Please notice that all the waves in AVR are negative waves. If you find the ECG waves are positive in AVR, this means one of two possibilities. Either the patient has dextrocardia, but a normal person without dextrocardia, if you find the AVR waves are positive, this means that the limb leads are not correctly placed. And this ECG is not correctly recorded. It is bad recording. Also, the position of the chest electrodes is very important because also if you put it in abnormal anatomical places, this will lead also to false diagnosis of diseases which are not there. Now we are ready to go in the next lecture to build on this foundation and start discussing the ECG waves themselves.